All right, welcome everyone to Thriving in Aesthetics. I am Dr. Sabrina Fabi, and I have my co-host here with me, Dr. Stephen Diane, where we're going to be talking today about strong jawlines and shapely necks. There have been many different products and devices that have recently been approved and indicated in the last year, I'd say,
Yes.
to help define this area, which I find can really be a signal and cue for an aging face.
Yeah, the neck is really important. And it's amazing. So many years we struggle with it non-surgically to find a solution to make the neck look better. But now there's been recent innovation with both devices, products, filler, toxins, and we've gotten significant improvements in the neck. Now, the neck, from me, I love studying about the science of attraction. And
Yes.
the neck has significant value. Not only is it one of the first places to start aging and reveal aging, and we're seeing a lot more of it in the GLP patients, it's also an area of social connection. So what do I mean by that? And I've done a lot of work on this, as you know, but it's an erogenous zone. It's an area of femininity. It's also an area of social connection. And women subconsciously will expose their neck and reveal their neck to someone they're attracted to. They don't even know they do it. There's some studies on this. In fact, I was reading one recently out of University of Missouri, where women would expose their neck and they would touch their neck gently, tilt their head a little bit, and that meant that was a subconscious signal that they were attracted to a guy. Isn't that
There you
interesting?
go. There you go,
So
guys. This is the
all these
reason why
interesting
people
tidbits.
are investing all this money, time.
And you can tell your friends that tonight when you go to dinner, okay? And you can say you heard it here on Thriving. So not only do we give you science, we give you all the stuff you can use to impress your friends at dinner.
There you go. So we've got a lot to cover today. We are going to be doing a presentation on just covering some of the anatomy that we're treating and the things that we need to watch out for when we're in this area. We will also be doing an assessment and a treatment so that you can kind of see all of that. But the most important thing is that underneath at the bottom of your screen, you have a little chat function. And I want to make sure that you're aware of that so that you can ask your questions throughout the program so that we can go ahead and answer them. Because ultimately, at the end, this is about learning, and we learn when you ask questions. So with that, let me go ahead and kick off with the initial slides that we just have to go over, just housekeeping, so that you're able to get your CME credit for today's event. And so this is again, strong jawlines and shapely necks, how to optimize safe and effective treatment combinations, because we recognize that one thing can't address all the changes that are accounting for the aging jaw and neck. These are our disclosures. We do a lot of clinical trials for many of the products and companies that we will be covering today. These are the disclosures of our CME provider, AKH. And this program is possible from a grant from AbbVie, so thank you to our sponsor. And then this is just information on accreditation. I will add the link shortly so that you can go ahead and click that at the end of today's program so that you're able to print your CME certificate. And so this is basically after completing the survey today that you'll get, you can print that. And this is just do a screenshot of this email right here for Trish if you're not getting your CME certificate. We will ask or answer questions throughout the program, so make sure to put your questions down at the chat function. So really, the objectives for today's program are to define the most commonly reported aesthetic complications that one can see. We'll answer those questions throughout. Relate and differentiate the different techniques that you can use and specifically compare them to the clinical trial because sometimes what we do in the trial and the techniques that we employ in the trials, what you and I have done a lot for many of these products are not necessarily what we do in real practice. And so we'll talk about that. Recall the manufacturing and property differences in some of the most popular devices, injectables and toxins, and how that may influence how you implement them when treating your patients. And then describe surgical treatments. That's why we have Stephen here today, when it's appropriate, when it's time to obtain the most aesthetically pleasing neck and jaw lines. We will definitely be talking about off-label use, which has been substantiated by clinical trials. So this is today's agenda. And with that, we are going to go into the assessment. So give us 1 second. All right, guys. So I'm here with our beautiful patient, and she's a perfect example of lower face and neck and how you can combine treatments to optimize results. So what she's noticing is a little bit of this excess tissue submentally. This is not always fat. It can be skin, especially when someone has fluctuated in weight between 15 to 20 pounds. I see that that can accumulate there, especially after a pregnancy. And so sometimes this excess bit of tissue or this excess bit of jowling can come from a lack of bony support. Now, she's Latina. And so what we find in Latinas is that this is the #1 complaint in them, generally as a function of age, actually more than under eye. So she's a perfect example for this segment. And so when I look to see if there can be some architectural support for this excess loose skin, I start with bone first. So that's the mandible. Now, she's not perimenopausal or menopausal. She's in her mid-30s, but she does have a weaker chin. And so you're going to look that way. Now, although Ricketts line can generally be more applied for a Caucasian face, you can see that it is applied for her. Tip of the nose, the lower lip hanging back, almost touching, it's touching it, the upper lip touching it, but you can see the most forward point of her chin, which we call the pagonian, is about 2 to 3 millimeters behind. So there's an opportunity to advance her chin forward to be able to meet the proportions of nose, lip, and chin. If someone like her presented and they wanted something to her lip, she would be someone you'd hold off on because you'd make her look ducky because she doesn't have the chin to frame the lip. So in augmenting, we'd bring this forward. Now, in that assessment, I also take a look to see, do I need to build the length of her face? And although, again, based on Caucasian characteristics, the upper cutaneous lip, 1/3, this lower cutaneous lip chin is 2/3. So she's pretty good on ratios. So I don't think she needs an elongation of her face. That might actually make her look a little witchy. So not everyone that needs a chin augmentation needs it in all of the 3 vectors. And so in her, pagonian prominence would be more pretty, but not menton prominence. And the Nathian is a point in between, which I'll address a little bit to bridge it to the menton. Then I look back, because remember that this is an entire bone. When we're talking about chin, we're talking about the mandibular symphysis. When we're talking about the gonial angle, it's the most posterior point of that mandible, where it really meets to the ramus of the mandible. And here, generally, you want a little more prominence of that gonial angle. In a woman, you want a nice 130-degree angle. If you sharpen it too much, you can masculinate her face by making it more of a 90-degree angle. So just giving prominence without changing the angle is important. And then how far low this angle should be is generally an imaginary line that can be drawn to her mental sulcus, which in her case, it's perfect anatomically. Her gonial angle is exactly at her mental sulcus. It's not too high. So it's not a gonial angle I'll want to advance or bring down, but perhaps one that I bring back. Because if I widen it, I can make her look more square, which we want to keep the face in a more inverted triangle shape. So when I'm looking, so we've assessed the mandible, we've assessed points to inject there. When we look at the lower face, I always look at the lip. It's a dimorphic facial feature. It's a signal of youth and femininity, and she's got beautiful full lips, so unnecessary to enhance. By putting something in the chin and labiomandibular sulcus, which is this sulcus that bridges the chin to the lower cutaneous or to the lower vermilion body, it will make this lower lip avert nicely, and it'll give her the appearance of fullness without directly having to inject the lip. But I always do look at the masseter and then the muscles. So we've assessed the bone. We've assessed a little bit of the fat along the labiomandibular sulcus. If you put stuff in the chin, you do need to soften that transition with the lip. Otherwise, the chin again looks very pointy and can look witchy. And so with her, I'm going to have you clench really hard. You can see a little bit of prominence of her masseter. Relax. Again, clench really hard. And so it's not what's accounting for her lower facial width. It's more the jowls that are accounting for the lower facial width. So then I move on to look at the platysma, because that's the largest depressor of the lower face. So I'm going to have you engage and show me your bottom teeth. Say E. And you can see here that it's engaging. E is one way to engage it. Now relax, smile big with your teeth, and you can really see that that's how she engages it. Good. Now clench really hard. That's another way to engage the platysma if somebody is using it because they're clenching, and that's not her case. Now smile big again. And so sometimes I find that when women complain of this double chin, it's really platysma, really clenching together and causing this. So I tell them that if I release that downward pull, we may actually see softening of all this redundant tissue submentally and along the jowls. So we're going to treat a little bit of platysma today. Again, say E. It's like a little bit of fullness primarily here. And so you can see that that's where the most of the platysma is, where it drapes over the mandible. And then lastly, we've assessed bone, we've assessed fat, we've assessed muscle. The last bit that I like to look at is skin. And so after I've done all of that, perhaps she might be a candidate for an energy-based treatment to lift the skin underneath the submentum area. This I generally do after I've provided good architectural support with my filler, good relaxation of my muscles with my neuromodulator. So with her, I would wait at least 2 weeks before I do any type of lifting treatment submentally. And in her case, you could do something like microfocus ultrasound or other ultrasound modality treatments in order to pick this up. I wouldn't do subsurface radiofrequency as she has no fat. So I don't think she's going to see as much of a result with this. And then as I work my way down the neck, she doesn't have crepey cigarette paper skin because, again, she's not going through these hormonal shifts that make the skin thinner. She has little horizontal necklace lines. So that's a great treatment for the newest gel to get approved, hyaluronic acid gel, 15 mg per ml, that can be injected into the lines. And then also that you can inject along the neck to kind of thicken up that skin. So we'll do a little bit of that, but she's not super deficient. And with that, that concludes our assessment, and we're going to move with treatment.
When you ask them to do the E's, you can really get a chance to see those platysmal muscles and see where that is. There's also a difference between submental fat and subplatysmal fat, and that's a big difference. And sometimes they're not the same. And a person can have a really full neck, and it's not fat that's superficial. So then it's hard to treat that with any of our energy-based devices or any of our non-surgical treatments. And that's almost always going to have to be a surgical treatment if we really want to get a nice improvement in those areas. Also, submandibular glands can be tonic. And you all know what those submandibular glands are. You're used to feeling those because there's lymph nodes around there. Every once in a while, those are tonic. And you cannot treat those. You can't effectively treat them non-surgically. Although I have done botulinum toxin there before.
Yeah, I think Tina Ulster published on the use of submandibular tox and reducing that. But you have to be careful if someone has a history of stones.
I don't worry so much about that, to be honest with you. I don't think that's too much of a concern, and you don't have to worry about not having saliva production. You have plenty of
Unless they have Sjogren's.
No, even Sjogren's, I'll treat them with Botox or botulinum toxin in that area.
Okay.
So I think it's an effective treatment. It's how much of an improvement are you going to get? And also you have to be careful, you don't want to inject into the strap muscles or any muscles that may affect deglutition or swallowing or obviously breathing, which would be rare. But if you inject quite a bit in the wrong areas, it could be problematic. Great.
And something that she had more masseter prominence, but another gland that sometimes can cause that lower facial heaviness is the parotid.
Yes, and it's often overlooked. And the parotid gland is a large salivary gland. It sits over the mandible and over the masseter. And people often mistake it, thinking that it's fat or it's jowl or it's mandible. It's not. And if you put botulinum toxin in there, you can significantly reduce it. Not only does it reduce peritonitis, which some people get, and people have Sjogren's syndrome, it's also big, but it improves the masseter and the parotid gland. So it's frequent that I will inject the parotid gland as well as the masseter to reduce the width of the jawline. But something else I want to talk about is the chin and
Yeah.
its influence on the neck. And this often gets overlooked. And myself, I published a paper on this a long time ago. I was early on, thinking in residency, showing that if you bring the chin forward, if you project the chin forward, you'll actually increase the cervical mental angle 5 degrees. 5 degrees. Now that's not insignificant. That's just by doing a chin implant. So a lot of physicians surgically will do that. You can also do the filler and get the illusion of improving the cervical mental angle. And it's a great way to make a jawline look much more attractive, both for men and women. Just where you put the filler in the chin makes a big difference.
Amazing. So those are just some pearls in talking about the assessment. Obviously, she doesn't showcase every single issue that might present to one. So I've created a presentation to cover some of the salient points that you really want to cover when you're doing an assessment, as well as treatment plan for a patient coming in for a more defined jawline and better quality neck.
Can we just one thing before we go into there, because
Yeah.
I know you and I published on this, ethnicity. And
Correct.
how does that influence your assessment? And you mentioned a little bit, she's Hispanic, you see some differences. But you and I remember when we were in Africa and we were doing thriving in diversity, what we saw the chins there were retrusive, yet they didn't want them treated there. Whereas it seems like it wouldn't fall within the appropriate lines, right?
Right, because in the Black population, there's usually more alveolar prominence that accounts for the lips coming forward more than the chin. And so if you meet that lip with the chin, it may not necessarily look anatomically pretty because their lips are coming out more forward because of their alveolar ridge, not because of lip volume, which is a little different than you may see in a Caucasian or a Hispanic. Another point is in the South Asian patient, which we saw when we were in India. They generally don't have a 1 to 2/3 configuration to base of the nose to the upper vermilion body, lower vermilion body to the menton. In fact, they usually have a more petite lower face that you have to honor and respect, and it's more of a 1-to-1 configuration. So those nuances in ethnic variation is important.
And Asian population, we were in Korea, I remember speaking with the physicians there, and a diminutive, a small chin was actually favored, along with much more of a defined jawline, but a narrow jawline. And that was considered more attractive there. So while we have certain parameters, we seem to alike here in the US, a lot of it based on European parameters that have been around for canons that have been around for years. The reality is that it varies by population and by culture. And I think it's important to be sensitive to that when you're treating the lower third of the face.
I could not agree more, Stephen. All right. And so with that, we're going to move on to the presentation. Let me have. And Stephen, feel free to pop in as I'm giving this if you have to add any additional color.
Okay.
All right, so strong jawlines and shapely necks. I had covered a little bit about the bone. With bone, we start to lose this bone in our face at the age of 25, becomes significant at the age of 35. But I would argue that there's probably more receptors when it comes to hormones that affect the osteoblast. So you don't have as much bony remodeling happening when you start to have those hormonal shifts in the 40s, which is probably the reason why you get that jowling in your 40s, where you see nasolabial folds or an infraorbital hollow in one's late 20s and early 30s, which coincides with the loss of maxillary bone support. But why all of a sudden the jawlines in your 40s? You don't see jowling in one's 30s, even though you're already having bone loss. So I think that there's more hormonal dependency of this mandible. And that accounts for the changes that we see, not just jowling and excess loose skin underneath the chin.
Can you comment on menopause in the bone loss? Because I know you've talked about that in the past.
Well, because those osteoblasts are very sensitive to that estrogen, right? Which stimulates bony bony remodeling. And so since we know that we go into perimenopause and menopause 48 years before you actually have cessation of your period, That's the reason probably I see the greatest shift in this population in one's 40s.
And 10 to 20% of bone loss happens after the first few years after menopause for women. That for men is not as effective. So I think that's one of the reasons also you see some of these jaw lines getting obtuse and less defined is because that bone loss. I know you've talked a lot about that too.
And so this is, the jowling might be the most apparent thing, but there are other nuanced visual cues from this bone loss that we see. A pebbling of the chin as the mentalis no longer has bone to really hold its and support its tone. And then also you start to see more lower teeth show. And so you'll have a lot of patients coming in wanting to get their lips augmented, and they don't even realize consciously why, but it's really to fill the lips so that they can cover their teeth. Because you don't see in a 3-year-old toddler like my son or our son lower teeth show, right? And that's a visual cue of age. And then we advance to the muscle component. And we have a lot of muscles that are supported by the fat and the mandible. The platysma drapes over the mandible, although it does not attach directly to the mandible, it does drape over it. And as a result, as that support or that architecture shrinks, then that pull becomes more noticeable. It has a pars labialis component attaching it to the orbicularis oris. So in a great paper that I'll cover momentarily, some think that it even contributes to some of the perioral lines that we see contribute by the orbicularis oris. It has a pars modiolus component, which really connects to the corner of the mouth, which is why people have this resting, angry face sometimes that contribute or is contributed by the DAO and the platysma that interdigitates with it. And then you also have the masseter that really adds bulk to the lower face, in addition to the parotid and those that have more parotid hypertrophy. But these are the muscles involved and that we have to be respectful of when treating the lower face, as you may not want to necessarily relax the depressor labii inferioris, as that will make the lower lip go up and make someone feel like their speech is a bit incompetent. Also, when treating the masseter, you want to remain posterior to the medial border, as you don't want to get strands of the risorius that can also limit the horizontal range of the smile.
Comment on platysma a little bit before we move
Yes.
on, but this is a bidirectional muscle, and this may be the most important muscle when we're looking at the neck and the way it works. It's a thin muscle, but it pulls up and it pulls down. It pulls up from the bottom and pulls down from the top. So what does that mean? You have to be very strategic when you're treating this muscle. The sheet of muscle connects the SMAS within the face, and it connects down to the pectoral fascia and the clavicle down in the chest and the neck. And when I'm sure you're going to talk about how we treat it in the area of the jawline, the neck. But if you don't treat it appropriately, you can actually get a pull down on the face, and you can actually look the worsening of the jaw. So you have to know exactly how you're going to treat it. I'm sure you're going to touch on that. Yep. So I'm going to let you get to that.
And then there's the fat. And to Stephen's point, there is this subplatysmal fat. And so when assessing somebody and having them say E, if they have fullness underneath that chin and they say E and that fullness disappears, that's usually an indicator that it's underneath the muscle, in which case your deoxycholic acids or even your lipo may not necessarily work as well, and it really needs some level of surgery. You also have supraplatysmal fat. This is the fat most commonly treated with cryolipolysis and some of the most superficial deoxycholic injections. And then you have jowl fat, buccal fat, and the deep lip compartments of the fat. And then the skin. The neck is probably such a hard area to treat because the skin inherently is thinner than other parts of the body. Our infraorbital skin is probably the thinnest skin, followed by suprapubic skin, but the neck skin follows closely. And not only is it thin, generally anywhere between 0.8 to 1.5 millimeters, especially as you work your way down to the lower neck, which is less forgiving, but also it has less pilosebaceous units. It has 10% of the number of pilosebaceous units that you have on the face, which makes it not as forgiving when using energy-based treatments that can potentially cause holes that really need reepithelialization from, because there may not be enough stem cells and reservoir to heal from, which is why you have to adjust your energy-based treatment settings, and perhaps the reason why sometimes injectables fall more into favor in this area. And so when looking at that lower face, I mean, this looks like an aged neck, right? There's dyschromia, that's that skin element. There's that obtuse angle of that submental angle that you talked about, cervical mental angle. You also have evidence of submental fullness, assessing whether it's supraplatismal, which is something that we can do with our aesthetic procedures, versus subplatismal, which is something you'd probably refer out to a facial plastic surgeon, is important to address. Determining if it's skin or if it's fat. And that one woman that I had assessed, it's skin. A lot of people today are on GLPs. And so sometimes the fat is gone and they're left with that redundant skin, in which case you're looking at more of an energy-based treatment that tightens or potentially a lower facelift.
Let's talk about the fat a little bit, if you don't mind me.
Yes, please.
Superficial fat, that jowl is a superficial fat pad, and that is one of the most common areas of complaints that I get as a plastic surgeon, because they want me to get rid of that jowl, and I will remove it, but with liposuction when I'm actually in the face doing a facelift. Having said that, as we age, we tend to think it's the deep fat pads that we lose below the SMAS. Now, that's a little bit different than GLPs, where we're losing a little bit more of the superficial fat. So it's really interesting how we're losing fat from different areas, but it's about 10% of your fat you lose per 10 kgs of weight loss. But as we age, we lose some of that deeper fat, we lose some of the bone, we lose some of the muscle, and then you see the jowls depend over the jawline. Very difficult area to treat, but you have to be cognizant of where that is when you're using fillers or toxins, because you don't want to accentuate that and make that worse.
Couldn't agree more. And so this is just kind of a simplified way of how I address the neck and jawline. I usually like to reduce the fat first, because no amount of filler that you put or no amount of neuromodulator that you'll inject will ever really be able to be appreciated if that inherent fat that someone already has there is not removed or potentially lipolyzed. So how do I reduce that fat? Well, you could simply do it with, let's see if Serge, perhaps you can help me with the video here.
This is liposuction or laser assisted?
This is lipo. And so here we're doing subsurface monopolar radiofrequency. With subsurface monopolar radiofrequency, it's not working. So, but it's to basically showcase that you can do tumescent liposuction. And then with her, we remove the fat and immediately follow it with a subsurface RF device that not only melts fat, because fat is sensitive to both time and temperature. So one consecutive minute of this radiofrequency heat will effectively cause necrosis of that fat.
How easy is this to do for someone who's not experienced?
It does require some experience, because if you disrupt or disturb the marginal mandibular nerve as you work your way along that jawline, then you can create a temporary neuropraxia of the marginal mandibular nerve, which can prove distressing to patients. But that's one of the complications in treating the lower face and jawline, is something that you could easily mask by treating the contralateral. And that's okay, Serge. I'm going to keep with this. You can treat the contralateral DAO and hide it, or the contralateral DLI and hide it. And so this is a perfect example. This gentleman came in and he wanted jawline filler. Now, if I added more jawline filler to lift this redundant tissue, he'd only look more of a trapezoid instead of a square, which doesn't make him look attractive. And so in reducing his fat, you can actually uncover the bone that he's always had.
How far out is he here?
Here he is 1 month out.
Wow, that's pretty good for 1 month.
For 1 month, it's pretty outstanding. I'll show you what I tell my patients when you use an energy-based treatment is that the results continue to evolve, because that heat is not only melting the fat, because fat's more sensitive to that heat than collagen fibrils are, which you're trying to basically break up to create or stimulate more collagen.
You need an extra device for this, and also you have to be concerned about the risk for skin injury too, right?
Correct. Because you could potentially, if you don't have a FLIR camera or a camera that's on top measuring that cutaneous temperature, keratinocytes also necrose at temperatures of 50 degrees. So that's the reason why you really have to be in the fat, so that that heat doesn't surface back up and potentially injure your keratinocyte.
Are you doing IV sedation for these patients?
With these patients, I am doing IV sedation, fentanyl and Versed. This is another example actually of one of my associates. You can see she has a lot of redundant loose skin. She's 60 years old. Here she is 6 months after the procedure. So again, showcasing no filler. If I had added filler in her face, she would have only looked wider and fuller. But by reducing the fat and uncovering the mandible she always had, she looks much more
How
attractive
common is it to get results like this?
from
Cryolipolysis and what you're
not
doing?
cryolipolysis,
I mean,
but from lipo combined with thermi-RF
Yeah.
in my practice, very common.
So look at this for a second. That when I do facelifts and people are going deep plane facelifts and doing all these aggressive facelifts, you're showing me a non-surgical approach, well,
Minimally,
minimally invasive
yeah.
approach where you're not cutting, and look at the next you're getting. I mean,
So
that says a lot.
so it really depends on what the issue is. And this is such a great point, Stephen. In her, it was fat. I mean, good amount of fat, and it was super platysmal fat. But if she had no fat and all that excess tissue was skin, she needs to see you. I can never treat this with with a minimally invasive procedure. If all of this fat was under the platysma, she needs to see you. I couldn't, she'd almost need a platysmal plication and have someone who's
Do
going to
you
be.
think you're tightening the platysma at all? Is that something that you believe is possible?
The
with it?
platysma is quite thin,
Yep.
and even if you really tightened it, I don't know how much of this it could cause.
Of it. So,
Now, not everybody wants that, even if you can promise them or show them this kind of result. And this is the very reason why we're in this segment today with y'all. Because even though Stephen can give them a much better result than I can with the lower face and neck lift, they don't want to give them the downtime. They're scared of surgery. They're scared of the pain. They're scared of the aftercare. And so even though I showcase those results, even minimally invasive procedures are scary for these patients. So this is with cryolipolysis. Is it as good as the result that you saw with the other patient? No. But listen, 2 cups, 50% overlap, 3 months later, it's better.
would you use the oxycolate?
No, cryolipolysis device.
A device.
Yeah. Now, this is an example of a gentleman. He didn't want to give me the time, very impatient, like someone I know. And so he didn't want to sit in my office for 2 hours as I did his cryolipolysis. He wanted me to just inject him so he can move about his life. And so here we did deoxycholic acid submentally. I usually do go up into the jowl area and inject no more than 1 cc into each jowl. That's a total of 1 vial. And we did 3 vials per session, 2 sessions, 3 months apart. And so this is it what you saw with the subsurface monopolar radiofrequency and lipo? No, but he was very happy. He looks about 10 pounds thinner. We've unmasked the mandible he's always had, and he looks more
What
masculine.
about the swelling afterwards of this treatment?
This is the dilemma with this treatment. And so in the trial, you and I were both involved in over 16 years ago. People would be injecting 4 to 6 vials, if you remember. That's why I kept it to 3 vials. That might mean that they need to do more treatments. We were injecting every month. Here in real life, I think you can actually go, those macrophages continue to engulf that fat for up to 3 months.
Yeah, it's a good treatment. It actually works. It failed in the marketplace. I think it's because the way we were doing it.
Right.
Patients didn't want to sustain
Every month.
Because if you did it every 3 months, just a vial, you could actually get improvement over time. That's pretty impressive, and you get skin tightening as well. What I'm really fascinated by here is all these procedures you're showing me are non-surgical. And it's how do you identify the best candidate for this? But you can get great results in patients non-surgically. But
Now, again, this is real fat. This is not
Yeah.
skin. So these modalities work when it's fat. And it doesn't have to be someone with excess fat. It can be even someone with mild fat off label, right? She had 2 sessions. In her case, she had 2 vials. I again worked my way up a little bit along the jowl. When treating the jowls, it's really important to pull that skin and pull it up and out, similar with Steve
So you
Yola.
inject the gel.
I do inject the jowl. Now, I do caution patients here that you can definitely inflame the marginal mandibular nerve, no different than if you mechanically irritate it with an energy-based treatment. And so that can happen in the trial. It usually lasted for no more than 6 weeks. And again, if you have a distressed patient, I just use 1 to 2 units of botulinum toxin on the contralateral DLI or DAO, depending on which muscle shows most significant impairment. And you can get a really nice result. Another pearl here to avoid a complication is withdraw back with this, because I have been fortunate enough to also get into arteries in the trial. I got into one, and that can absolutely cause a necrosis of the skin because it essentially serves it, right? It's a lipolytic agent. It can absolutely disrupt the endothelial cells that line your blood vessels and create a slush-like effect. And so therefore you can get a necrosis of the skin.
So maybe there's a role for deoxycholic acid, which we haven't really talked much about in the last few years.
Right. So especially for the jowls, you've done all these things, you've optimized their jawline with bone and with filler, you've tightened up all their skin, but they still have that little excess fat. You're not going to subject them to a facelift. A little bit of deoxycholic acid is not a bad idea. But if they have excess super lax skin, you may make it worse, don't you think? If you reduce too much fat with deoxycholic acid?
Yeah, I don't, in theory, but I don't know if I've seen that.
Okay.
And but is there anywhere else on the face that should put deoxycholic acid? other
No,
than
I
jaws?
won't do the infraorbital fat pads. I really respect the eyes. That's not an area. There's an arcata vessels there. You definitely don't want to get into one of those
Yeah.
and potentially affect, the globe.
I have one patient I treated her temples because she had fat that she couldn't get rid of, and she was upset about it from fat
From
transfer.
fat transfer.
Yeah, I was able to resolve it.
Okay.
That's it. Yeah.
My combination pearl here is relax the platysma or DAO 1 week before lipo to minimize this temporary induration that can happen, especially with energy-based treatments, because you're delivering a lot of heat there, and that platysma can get indurated and hard for 6 to even 12 weeks. And so my pearl, after doing this for the last 12 years, is to just relax the muscle.
So you're talking about when you're putting in a light-based,
Energy, yeah.
but that's subdermal, under the
That's
skin.
subdermal, but that heat it's monopolar, right? So
Okay.
it's not just going up, it's going down and heating
But
the
for people who
platysma.
don't want to even make an incision to the skin, what do you think about topical, like microneedling, not microneedling, RF microneedling, or
If they have fat, it's a good treatment. The FDA came out with a warning that microneedling RF can destroy fat, right? If you're at 3 millimeters or 2 millimeters, your fat definitely is there, especially along the upper neck. And so it could potentially, although I'm not aware of any clinical trials that showed that microneedling RF has destroyed fat intentionally or that it has that indication, it is a warning.
but there's a lot of people out there who have devices, radio frequency devices, they're using externally on the neck skin.
Now, I would caution those people if the person has no fat, because it may not be the best treatment, right? Because you want to preserve the very little fat that these people have. That fat has cutis retinaculum, which is the fiber septae that run from skin to underlying platysma. And so if you destroy that entire cutaneous retinaculum network, what you could essentially do is create skin that's dancing and gliding over the platysma, and now it looks even worse. And so we did a clinical trial in our practice. Monica Bowen was the primary author in that trial. Nina Hartman led it. And so here we compared microneedling RF to non-ablative fractionated laser, the 1550 nanometer erbium doped laser, to determine if one was superior to the other when addressing the crepiness of neck skin. So not lifting, we're not talking about lifting, we're talking about the crepiness, the superficial changes of the skin. And what we found was that 3 treatments of non-ablative fractionated laser treatment was superior to microneedling RF.
Okay, but so what's your thoughts? We have microneedling,
If the person has
RF,
fat,
a lot of people are
if the
doing it
person
without
has fat,
the skin tighten. You a fan of it?
for
We
crepey
do a
neck
lot of it here
skin,
in my office.
for crepey neck skin, no. For somebody who has some fat that they can get rid of and you don't want to go into injecting them or doing cryolipolysis or deoxycholic acid, I think it's
I
fair.
don't think you get neck tightening.
Not in my personal experience.
Okay.
Teeth. We cannot neglect the lower face or talk about it if
Those
we're
are
not
really
talking
good.
about teeth. Well, I thought they were cool. What did this person have done? What do you think?
Looks like a little bit, well, first she's pursing. And not
Okay.
that much, not pursing a lot, so it could have been tox.
Mhm.
And it looks like her lips are a little more defined, so I would say toxin filler.
No, all she had were dentures.
Ah.
And so in a trial that was done, and this is the reason this really just focus on this
Yeah.
this slide everyone's seen. There's always a focus more on the piriform fossa. Forget the piriform fossa. Look at the more obvious point. Look at the alveolar ridge of this patient. Look at the teeth. Look at how much protrusion how much protrusion they once had and how much protrusion they now have. Think about the lip following these teeth. It kind of inverts in. It causes the oral commissure. It causes the labiomandibular sulcus. It causes the melomental fold. It causes all the issues. So I sometimes tell my patients, listen, if you want a natural result, go invest in some teeth. They're much more expensive than your facelifts and my injectables, but your 10-year older self is gonna be so thankful to me. And so teeth play a role in supporting that lip and all the issues around it, including the jowls. And so this was a really interesting study. They took 31 patients, mean age 62, the age ranged from 47 to 77. And in just putting dentures, there was a significant improvement in the aesthetic scales that we use in practice. Upper and lower radial cheek or radial lip lines, marionette lines, upper and lower lip fullness in the nasolabial folds, as well as the corners of the mouth.
It's a
So
really important point because we kind of overlook this in our field a little bit and we're negligent on this. The truth is that teeth
I'm
make
not.
Okay. General field. We don't talk about this. We talk about the lips. We talk about how to treat the perioral lines. But you bring up a really strong point. And oftentimes it's the bone and the dentin that
It's the architecture. Without good architecture, it's over, game over.
Build the lips and not get a good result. And it can come down because the fact is the teeth are not right.
The teeth aren't averting them, right? And so here, the biggest pearl is after the age of 40, teeth start to shift, go see your orthodontist, get some Invisalign.
Invisalign.
Yeah. And so when talking about the lower face, again, based on more European Caucasian standards, but this just kind of creates some guidelines that we're looking at, right? I talked about the base of the nose to the vermilion body, 1/3, 2/3, even in a man. And so that one model that I assessed, I didn't put anything into her menton because it wasn't necessary because she already had a long menton, but she needed Pagonian support. In this model, you can see that she doesn't need just
Pagonian, the most projecting portion of the chin.
Right. She doesn't need just Pagonian support. She needs lengthening. And look at this Latina, 1/3, 2/3 after injection of Pagonian, menton, and Nathian with 2 cc's of HA filler. So this is another pearl for me. I think you were involved in the chin trial using a 20 mg per ml HA gel. What we found in that trial, I was a sub-investigator, is that this is an area, it's a tight compartment. If you put more than 2 cc's in one session, people feel very limited in their animation and movement and even report a little bit of pain because they can't open their mouth when they chew and talk. So maybe in my practice, at least, I do like no more than 2 cc's and then invite them back 2 to 4 weeks later for another 2 cc's.
So I think this is an area that takes a lot of nuance to treat it well, and you got to be careful. And where you place it, women, you want to stay within the inner canthal distance, so it's a narrow injection. For males, you can go a little bit farther wider out to the oral commissure down, and that's your line for where to inject. And you have to be careful because of where the vessels are that are coming up over the submentum. I'm not sure if you're going to talk about that. And okay, good, you have that there. And then I will oftentimes make it the pre-gel. So if you make this too full and you don't treat the pre-gel, you can actually get a dip in the pre-gel and actually looks worse.
I agree. So all those are points to consider. Look at how her lip has been averted by just putting something to support her labiomandibular sulcus. And so this is a person just to kind of show the importance of architectural support. Yes, she has a little bit of fat and a little bit of excess submental skin, but when just addressing her jawline and chin with a total of 4 cc's, in her case, I did 2 cc's of CAHA and 2 cc's of an HA gel, you can see that it looks better and that redundant skin is better.
But you did nothing to the neck.
No, this was a live model. This was a live injection. So this is immediately after, actually. So this is just to prove. In practice, I would have actually recommended
the projection of the lip, the lower lip.
Yes,
that is impressive.
Without putting anything in the lip. So this is the key. The patient will come to you asking you for lip, but they don't know what they don't know. What they don't know is that what's really bothering them is the lack of lip
I did a paper where I filled a piriform aperture and projected the upper lip forward. I don't know if I've seen a paper showing projection of the lower lip with placement of filler in the chin.
That's an outstanding idea.
Yeah, maybe we should write that up.
We should write that up. This is to show that there's longevity in these products. And so this is 9 months after 2 cc's of a 25 mg per ml HA gel along the jawline and 2 cc's of a 20 mg ml Vicross gel in the chin. And you can see her 9 months later still showing improvement. Now, these are just some cautionary.
What results do you get from this?
If I did 4 cc's of HA filler, I tell them come back at a year, you probably aren't going to need more than 1 cc.
Are you going to talk about where you inject, how deep or superficial?
Yeah, I'm going to show the injection. So moving along, things to be cautious about. Look at this gentleman's before photo. And then after I injected him, unfortunately, the build out has been removed. But you have to be careful not injecting a man like a woman if he's a man and he identifies as a man, as you're going to feminize his jawline. So here now he looks more feminized because he has a more 130-degree angle to his jawline. With men, not just the width of the chin, to your point. In a man, it can be as wide as an oral commissure. In women, it can be as wide as medial canthal lines, but also the bizygomatic distance to the bigonial distance. In a man, it can be a 1-to-1 ratio. In a woman, you maybe want it more 1 to 0.7. And so otherwise, you can, in a woman, masculinize the face, and in a man, you have an opportunity to build it out. So here, he's a male model with 3 syringes of Kaha 3 years later. This is just to show how there's a longevity in these products. You'd look at him in the before and you'd say he's perfect, but he looks much more handsome with just widening, adding width to that lower face, and creating more projection. And then this is to show by building that, this is another associate of mine. I thank all my colleagues for letting me model them. You can see how you pick up that jowling. So sometimes patients come in, just inject my nasolabial fold, inject my buccal fat area, but really it's a lack of bony support posteriorly. And if you inject that, you can
Where'd
really.
you inject him?
I injected the posterior jawline and it picked up all that redundant tissue. This is to highlight that if you inject a woman's mandible, like you inject a man's, you might masculinize her. So different ways to inject different people, anatomic areas or things that you want to consider. You want to inject posterior behind the masseter muscle. There's a lot of masseteric veins. So if you're injecting on the masseter, it can definitely lead to more bruising. And then you also have the parotid gland that you have to be thoughtful of. There have been cases of getting into that gland, and even the parotid duct. Relax. Muscles also contribute to width and heaviness. It's not just fat. In her case, she's all muscle. You can see that it's her masseter that's really causing that bulkiness. Here she is 2 weeks after treating botulinum toxin to the masseter, a total of 36 units, and then just using strategic placement of very little filler to really highlight the more sexually dimorphic structure of her face, which is that point where light reflects off the high cheekbone, and then a little bit into the lips. And then there's the role of the platysma in the lower face and neck. As I mentioned, it's the biggest depressor of your lower face. It can really blunt that jawline. It almost looks like she's full underneath her mandible, like it would be fat, right? But it's all platysma. And so a paper that really changed my practice is that by Ada Trinidad and Jean Carruthers, talking about how it doesn't just blunt the jawline, it also causes radial cheek lines. A lot of women come in for radial cheek lines to my practice. When they smile in photos and selfies, they hate all these lines. Look at the platysma, because you may not need to fill it with anything or laser it with anything. It may just be, they actually might be disappointed if you do that because the muscle is still active. My points of injection are 4 units into each DAO. And then I do 4 units in the 3 points that really hover underneath the mandible, and then 2 units along each band.
What caveats do you have for injecting in this area? What do you careful for?
Be careful about putting too much in the center of the neck, as sometimes there could be spread into the strap muscles. Into the muscles of in swallowing. And also in the original trial that was done out of Canada, I want to say it was a phase 2 led by Jean Carruthers. When they did 72, when they did different, amounts, what they found was that it was really when you started going over 50 units into the platysma of botulinum toxin type A that you started seeing more AEs, problems swallowing, etc.
I was actually in that study. It was up to 72 units.
Yeah.
It was a dose ranging study, and the results, while they were good, they weren't that much better than doing the 36 units.
Right.
And there was a few more AEs with swallowing and lifting your neck.
I really want to highlight that this is something that can be used in men. Men come in a lot for their jawline. Sometimes it can just be simply relaxing the platysma that can help really sharpen and highlight the mandible they already have. This is to highlight again the radial cheek lines. If you only treat the crow's feet, they'll come in complaining that they still have lines down here. That's platysma. It's not crow's feet. It's not orbicularis oculi muscle, and they don't necessarily need filler. And look at all that redundancy that even carries submentally.
Are you putting it along the jawline like Ada talked about?
Above the
Above the
mandible,
mandible.
I'll be very careful. I'll do like 4 points of 1 unit each. They did 4 points of 2 units each. You just have to be careful getting the rosorius.
Right, you have to careful the Rosorius and also the DLI. So you have
Yeah.
to stay posterior to the DAO is your last injection. I do it a lot. I kind of like it. I think it gives a little bit more of a jawline definition.
I just want to make sure that there's no questions that I've been missing. Okay, no questions. Okay, this is an example of someone again comes in with a lot of lower facial heaviness. She's young. You would want to put filler in her cheek, or that would be what she came in for. I'm like, absolutely not. First, let's debulk your lower face. So I debulked her masseter with again 36 units, and then treated her platysma and mentalis.
18 per each master.
I usually do 10% more in the bigger side. In her case, her right side is bigger than her left. You usually chew on our more dominant side. And so that's what I find in her. And then I treated 4 units into the mentalis, 4 units into each DAO. And so now she also doesn't have as much corner pull inferiorly. This is an example of another person who came in wanting me to do lipo to her jowls. I'm like, ooh, when I look at her, it's really a debulking. So by treating her platysma and masseter, this is 3 months, this is 2 months after her second session, you can see her face has reshaped upward almost. So, and even in an older person, you can really show that it can, that
What'd
like
you do here?
the vector, right? I did neuromodulator in the upper face, orbicularis, oculi, glabella, as well as platysmal tox and a little bit of filler along the cheek and gonial angle. And so now the vector of her face has changed, and she's 72 years old. And so then we conclude with redraping. Obviously, the gold standard here would be a lower face and neck lift. But there are, devices that use ultrasound or microneedle RF. In this case, I use microfocus ultrasound. Here she is 6 months later with 2 syringes of an HA filler along her chin and jawline, and she looks better. So it can help not just that
Her skin
redundant
looks better
skin,
too.
but it can improve the quality of skin. And I think that these devices focus so much on lifting, but there is a skin quality improvement because anytime you stimulate collagen and elastin, you're going to improve quality. And resurfacing. We do this proprietary Take 10 in my practice where they combine a fully ablative CO2 with a fully ablative erbium around the eyes to really tighten and contract that skin. And then also sometimes use fully ablative CO2 to the whole face or even a fractionated CO2. And you can see she looks better after a combination of lasers. In her case, not all, puffiness around the eyes is excess skin. It was a blue vein for her. So you can definitely combine lasers to improve the quality of the skin as well. And so in conclusion, you can kind of see the conclusionary slide. I'm going to jump past this in the sake of time because we still have an injection that we need to show. But again, if anybody has any questions, feel free to ask them in the chat function box. If not, Stephen, anything that you want to
I
add?
have a lot, but we only got 7 minutes left.
So
you should probably watch
let's
videos.
go ahead and see what we did with our model. So here is that beautiful patient again. I'm injecting using a 25 mg per ml HA Vicross gel. I first injected her Pagonian because I told you she didn't need anything in her Menton. I put a little bit into, look at how it almost
Wait, what are
lifted
you
that one
injecting?
side. Here, I'm injecting a 25 mg per ml Vicross gel.
And you're going down to the
I go
bone?
down onto bone.
And you're using a 27 gauge?
I'm using a 27 gauge manufacturer needle that comes with the
You're
product.
not aspirating.
I do aspirate always, especially along the chin. We know that the submental artery, which is a terminal branch of the submandibular artery, which is a branch of the facial artery, has connections to the tongue. right?
Yeah, they are. So you're injecting with the needle down to the bone.
Down onto bone.
And then on the mass on the mandible too.
And then along the gonial angle. So here you want to be very careful that you know where your antegonial notch is so that you don't get into the facial artery, right? So I
Or go
would,
behind the mandible. There's reported cases of getting into the retromandibular vein.
right. So don't, it definitely it's an area that if you don't feel bone when you inject, you get out. And I always tell my fellows that.
I inject superficially here.
Okay,
Some
so
people.
here you see my angle is not to add width to the face, it's like posteriorly. And now I work my way up the posterior segment of the ramus. And you can see I inject, I would
Very
draw
little.
back very little. This product has a lot of product efficiency, like zero point 0.1 cc's, 0.05
This is
cc's.
the FDA approved one for
This is,
the.
yes. And it kind of picks up all that excess tissue that she complains about, along the very early jowling that she has.
Yeah.
So she doesn't need loads of stuff. She has a little scar on the left-hand side. So I just want to highlight that that's not a pre-gel sulcus. And so now I'm doing a numbing, now I'm doing a little bit of toxin. And so I do the toxin before I start injecting with my cannula along the mandible because there's lidocaine in this product. And if you numb the platysma, then you're not going to be able to see anything when they say E. So here I put 4 units into the DAO. I draw a line along the nasolabial fold, melomental fold. I go 1 centimeter posterior, and that's where I inject my 0.1 cc's of anobotulinum toxin.
So you don't pull the platysma out when you inject it?
No, I don't, unless I'm treating a band.
Okay.
Here I
Making
do,
sure you say superficial though.
right. I mean, this is a very thin needle. This needle is only 2 millimeters.
Okay, your chin toxin injection, are you careful to stay medial here or?
In my chin tox injection, I just did 4 units centrally. I don't do 2
What's this here?
injections.
This is toxin.
This is toxin again, along where the platysma drapes. Now, I just want to pause because I know it's moving quite quickly. So I want to, this is toxin. What did you do for the large vein of the cheek? Oh, I did a long pulse 1064. Thank you for the question, guys. Excellent treatment. So going back to the jawline, because I don't want to, I want to highlight what you're saying, Stephen. Here I'm using botulinum toxin. I do 4 units along 3 injection points along the base of that mandible where the platysma drapes. Now I've switched over to lidocaine with epinephrine injection. So what I want to highlight here is that I don't numb the jawline with where I'm going to go with my pilot needle and cannula until I treat the platysma with toxin because the lidocaine numbs the platysma. And so then when you have them say E or smile, they can't even do it. So then you may not get as efficacious of a treatment. This is where I'm going to go in to treat my labiomandibular sulcus. I draw a line down
This is
from,
top, what are you?
this is lidocaine,
This is-
lidocaine with epinephrine. I use a 22 gauge cannula as my a 22 gauge cannula to inject. It's a blunt tip tube. I used a 21 gauge pilot needle. That's the green needle. And now I'm going in with my cannula.
Going anterior, this is superficial.
This is now superficial. And this is really important, Steve, because here, if you're deep, you can get into the parotid, which I don't want to obstruct. It appears I have another question. Do you ever do 2 Mentalis injection points? Steve, do you ever do 2
Yeah,
injection
I have
points?
2 points right in the midline.
Yeah.
And
Because
that's
you do
superficial.
you have 2 bellies of the Mentalis, one on each side. I just inject where they meet so I can, minimize the risk of, transfer to the DLI because the Mentalis is deep and then the DLI drapes over it. It's a little more superficial and the DAO is the most superficial, but I just do 1 injection where the 2 bellies meet.
So and I'm a little more superficial when I'm injecting the mentalis muscle because I want to get rid of the pudendals.
So I go deep because I want to avoid the DLI. So I guess, there's no indication for treatment of the mentalis, which is the reason why we have all of our different ways of doing it. But there is a great paper by Jeffrey Kenkel for those that are interested. He injected the mentalis and was able to shift the pagonium by 1 millimeter inferiorly when injecting 15 units of anobotulinum toxin. So that's important to know. So
Look at you, you're superficial
I'm
and you're
super-
deep on the mandible.
Right.
With
So
the
I did
filler.
a
That's
deep
what-
injection on the bone,
Yeah.
and then I do a superficial injection to really bridge and highlight that 130-degree angle to the mandible.
Like
with
a contouring, like makeup, right? Or
right.
you would,
So now I'm treating the labiomandibular sulcus. I'm using a 20 mg per ml HA gel that's approved for the chin. And so I first start by advancing the tip of my cannula to mental sulcus, and then I kind of fan throughout, working my way all the way up to the vermilion body and coming down.
you're superficial here.
And here I'm under orbicularis oris, but over DLI.
And what cannula size is that?
I'm using a 22 gauge cannula. Look at the difference. Do you see how indented she is where I am compared to the other side? So this is the technique that was able to avert that lower lip
Do
that
you
you're
get a lot of
talking
bruising?
about. No, because my injection point is really inferiorly. And the cannula, although we know it can pierce an artery, it's been able to cannulate. I was able to cannulate a superficial temporal artery with the 22 gauge. It These vessels, the labial artery could potentially, it's a larger artery, could potentially pierce it. Now here I'm navigating the mandibular ligament, which I know you, Steve, subsize. Some people claim that they can subsize it.
Well, it's a true ligament.
Right. With a cannula, I don't think you can subsize it with a cannula. But I'm just gonna, let's see if we're able to see her. So now her lip looks better just by injecting the labiomandibular sulcus.
We did a study a few years ago showing if you lift the corner of the mouth, people actually felt better. Not only did they look better, they felt better.
The connection between the,
Emotions,
and expressions, right? With the concept being that if you reduce the expression, the emotion follows. So here I feel the masseter. I stay 1 centimeter posterior to the medial border. I am inferior to an imaginary line drawn from the tragus to the oral commissure so that I don't have any spread upward to the zygomaticus muscle. And I essentially inject triangle, an inverted triangle is how we did it in the phase 2 and the phase 3 clinical trials. Again, staying 1 centimeter posterior.
Easy treatment and very satisfying.
Very satisfying. The biggest complication you can get here is that you can have a paradoxical hyperplasia of the muscle or prominence of the muscle when you clench after treatment, and that's because sometimes the superficial fibers aren't adequately
You don't get all the
treated.
belly, so it's easy to treat. You just
Right.
put a little bit more in and get rid of it.
And so then this is the key here, Steve. Here I'm using the newest 15 mg per ml gel that was approved. 15 mg per ml. It was approved with a 25 gauge cannula to treat subdermally. You can see how superficial I am. You can see the tip of my cannula where you didn't see it when I was treating the labiomandibular sulcus. You didn't see it this superficially or gray when I was treating the gonial angle, but here you can see it. And this is how we essentially covered an entire area. In the trial, we injected a total of about an average 3 cc's total in the first session, spread between treating the entire field of the neck and then going into the individual horizontal necklace lines. The indication is for the necklace lines. I do little numbing dots with lidocaine with epinephrine, and I go anterior to the sternocleidomastoid muscle. There's a lot of little fibers, especially in somebody that's young like her. That's all that cutis retinaculum, right? That's adhering that skin onto underlying platysma.
So your pilot needle is over this SCM?
Yes.
That's right.
And it's along the medial border because if you're directly on top of the SCM, what I find is that there's a lot of fibrous attachments from the muscle to the skin, and it's very hard to enter. So go along the medial border of the SCM.
And then you're coming medial also. You're doing the medial.
And then now I'm using the needle, which is how we did it in the trial, to inject along the horizontal necklace lines.
Are you injecting into the necklace?
Into the necklace lines themselves. Now, we treated moderate to severe necklace lines. In this person obviously has more mild
Are you
necklace.
subdermal or dermal?
I am subdermal. I think that with this product, if you are truly intradermal, it bumps up. And so you can see we use a cotton tip applicator to massage immediately after. And I tell my patients for 1 week, they may have little bumps and they will integrate over that time.
How much bruising and swelling do you get this in the neck?
You can get some bruising along the necklace lines, I find. But
So if you tell them it's a no downtime procedure, or do you say
you may have some bruising, just like you have bruising and the potential risk of bruising with any injectable that I do.
all right?
So with that, any other questions, Serge? I want to make sure we answer them. Nope. All right. Well, we're 4 minutes past. I want to definitely thank everyone for joining us today. I hope that this has proven to be beneficial and useful. Again, if you have any questions, we'll let you ask them now. Stephen, any thoughts?
Well, we're
Like
back August 6th,
Sixth.
our next show, and for that one, we're doing vanity to vitality. That should be a good show.
Yeah, I think now more than ever, I think all of us have been doing longevity medicine before it's become a mainstream thing. Anti-aging is ultimately longevity, right? And so we just do it aesthetically with procedures to be able to biologically reverse the changes of cutaneous age and maybe perhaps even bony age. So at least the appearance of it. Other people are now focusing more on the systemic and the internal longevity, but we've been doing it at least externally for, gosh, over 25 years, right, Steve? You.
Yeah. And if you want any topics for us to touch on or to tackle, let us know and we'll submit it.
All right. With that, thank you guys so much for your attention today and see you next Thursday, August 6th at 10 a.m. Central. Bye.